from Colorado?
Iowa.
Iowa. Awesome. Did you drive?
Yes.
Ever? Of course.
Yeah, we're from Missouri.
Missouri drove.
We're at
That's a
Springfield area.
boring
Springfield,
drive too.
We're at Iowa. You guys from?
Springfield or Trumbull.
Okay, I grew up in Sioux City.
Okay.
That's where I was born and raised.
How old are people's girls? 10 and up? 6? 4? 5? 16? 12?
19.
19? All right, good. 10. Awesome. I can get started. What do you think? Give people another minute? Was there a big traffic jam? Yeah, that was a traffic jam. Yeah. It's always something.
So here's your
Oh, thank you.
Just forward back, and the red line is a laser pointer. if you need it.
Awesome. No, I'm afraid of laser pointers, but.
Okay.
Too much coffee. I am like all jumpy. I'm like, so if anyone else wants to stretch or jump around, I might be.
Yeah, you want to start us off with a yoga class?
Yeah. You know, the other thing is it's been so hot that like it feels so cold in here. I think that's also I'm like shivering. Yeah, I do a lot of yoga. I don't want to leave anyone out, but I don't want to get in trouble starting to occur. There's Amanda. She'll tell me what to do.
There were a lot that were talking.
Good thing you made
It's up to the restaurant.
Yeah, yeah.
Or the coffee bar.
Coffee. Right, so then they have to go back one again.
Yeah, I don't want to start too early.
Hi, Teresa. She's my sister.
All right, I think we should get started. All right, let's get started. So we have, could you, there's a camera for recording, so I'm trying to, otherwise I would wander a lot. I want to thank the tech people for getting me a laptop. Somehow I went somewhere without my laptop today. Oh, what was I thinking? So Amanda and I talked about this talk, and we changed the name to just be Reproductive Health and Periods and Puberty for Girls with Special Medical Needs. Because, of course, and actually I think this talk is helpful for all people, all girls, all women, and we'll talk about why sometimes people don't get the information they need about reproductive health. I am a gynecologist, not a pediatrician, but I only work now at Children's Hospital. I worked in General GYN for many years, but then figured out that I just love taking care of teenagers. Definitely my favorite group of people. I just love their energy. I love the potential of taking care of teens. Definitely one of the my missions in life is to get rid of the teenagers kind of thing that our society does. I think that it's just so, to me, I find it so unfair and also just not the reality. Teenagers are amazing, so hopefully you'll get a little bit. And puberty, no matter how you feel about it, it's you might as well be positive about it because there's nothing you can do to stop it. So anyway, I work here at Children's Hospital. We have a primary care clinic called the Special Care Clinic, where that sees kids with complex medical needs. So I take care of lots of girls who have complex medical needs. And then I also see lots of girls in my clinic here. I go to the South Campus in Highlands Ranch, and I also go up to the Broomfield clinic. So I've been at Children's for 5 years. So over the last 5 years, I've treated hundreds and hundreds of girls with special medical needs. And you know, it is a biased group. When families come to me, I think they're already thinking about hormonal therapy, and we're going to talk about that. You know, you may absolutely decide that your child doesn't need hormonal therapy, but I want you to at least be aware of what's out there. So these are topics for today. We will talk about puberty, we'll talk about periods, and then we'll cover some other issues. I would love to be interrupted, and also I can stay till 10, so there's that break until 10. So if we're done at 9:45, please feel free to leave anytime and come back. But if you have questions after, I'm happy to answer them for you. I get a ton of referrals from our rec clinic too here, so that's why, that's how I met Amanda. Do you all know the Runaway Bunny story by Merrick? Oh my gosh, it's my favorite child story. I read it hundreds and hundreds of times to my kids, and it's about this bunny. I think it's Margaret Wise Brown, and it's about this little bunny who just keeps changing, and the mama then changes. And when I read it, when my kids now are 15 and 17, and when I read it to them, I had no idea. I mean, I loved it, but I didn't understand how true it was. So basically this bunny is like, well, I'm going to become a bird. And the mom's like, well, then I'm going to become a tree, you know? And then, and this is what I think we do as parents. Like, the second we get something figured out, then we have to, everything changes, and we have to figure it out again. And I don't know what the exact connection to puberty is, but I just want to thank you for being here. You as parents matter so much. Like, all of our caregivers should know a lot about reproductive health. And all of our teachers, but whether they do or not, you knowing about it is really, really important. The other thing is that information really matters when it comes to women's health, reproductive health, and sexual health. There are a lot of taboos. It's not something we get a lot of training in medicine. So information is really powerful. We don't dispute that with any other area of health. You know, we want to understand all the systems, but for some reason when it comes to sex, well, I don't know if we want to explain that. Like, I'm perplexed by that. And then the other thing we already kind of referred to, that this is going to happen. And I want you to see it as a positive as much as possible. You know, kids that don't ever go through puberty, there's something wrong. They're malnourished, they're overstressed, they don't have ovaries. The fact that your girl starts to produce estrogen, and we'll talk about the processes, but that's a sign that her brain is talking to her body, and her body is talking to her end organs in a really important way. It means that that her body's working, okay? Okay, so where does puberty start? So puberty, we're gonna get into this a little bit. Puberty is defined as the body's change from a child to an adolescence, and someone becomes capable of human reproduction. The signal starts in the brain. The brain sends a signal to the pituitary to produce LH and FSH. Those feed down to the ovary in girls, the testes in boys. The ovary makes estrogen, the testes makes testosterone. Okay, so in girls, and I'm gonna focus more on girls because I'm a gynecologist and because most people here have girls as well. Estrogen is then responsible for the physical changes of puberty, okay? Adolescence is a period which begins in the preteen years, and we know that the brain, especially in boys, 25, 30 before the brain is completed with adolescent brain changes, and girls 20. Adolescence is so much more than the physical changes. And the physical changes do not correlate with the emotional and cognitive changes. And especially, you know, when I'm talking to middle school kids, you know, a lot of times parents will be worried, or teachers will be worried about a girl who has started puberty early. That is ridiculous to think that for some reason she is cognitively more mature than a girl who still has a chest as flat as a board. Okay, it doesn't work that way. All of these things, you can be advanced in one area, delayed in one area, and one of the hallmarks of adolescence is just inconsistency. You want to be super independent, and then the next second you want to be a baby, okay? And let me assure you that estrogen and testosterone in boys is not responsible for all of these cognitive, behavioral, social changes. I see kids who don't have ovaries. They're never going to go through puberty naturally, and they still have the same struggles of adolescence as kids that do. They are still talking back to their parents. They are still wanting to be adults one day and babies the other. Does that make sense? So I just encourage you, as puberty occurs, it's tempting to get carried away, and definitely in our society we have a lot of interesting things about hormones. There are lots of hormones in our body. The sex hormones are estrogen, progesterone, testosterone. Most of the hormones that modulate our moods and behaviors are, neuroendocrine hormones, right? Dopamine, epinephrine. So just to kind of know that information-wise, I think of the sex hormones kind of like the weather. It's not that, they influence how you feel, right? If you love rainy days and you go outside and it's a rainy day, you're gonna be like, yes! Or if you love the heat. I mean, the sex hormones definitely influence these areas, but they're not the end all or be all. When you need help in behavior and cognitive and all these other areas, get help in those areas. Don't just see the gynecologist, okay? And I work a lot with other providers in these areas. Okay, so let's get into the nitty gritty. I think this is the most useful thing that you are going to learn because for whatever reason it is not common knowledge. Your daughter, so in the beginning when she's born, she still has mom's estrogen in her body. So girls, when they're born, infant girls, will have a breast bud, and then there can also be some bleeding, like in that first couple weeks after you have your baby, and that's because the lining of the uterus, her uterus, was exposed to your estrogen hormones, and the lining sheds. Okay, so I don't know if you saw that with your baby. If you did or not, doesn't matter. Then estrogen is gone in her body. Estrogen levels are super low until the brain sends a signal to the ovary to start making estrogen again. The average age is 10, but 7 or 8, it can start as young as 7 or 8 that estrogen starts to be made, or it can start as late as 13. So if you have not seen breast buds by 13, talk to your doctor. If you start to see breast buds before 7 or 8, that would also be a reason to talk to your doctor. And of course you're going to talk to your doctor either way. But just so you know, the ranges of normal, those are the ranges for the onset of puberty in girls. And estrogen causes breasts to grow, and so the chest, which was once flat, will now develop, there'll be like a bud under the nipple. It may be tender. It actually feels like a nut. One may come before the other, and then after the nipple, you'll start to get a mound, and there's a staging of the breasts, and it's amazing. Estrogen over time changes the shape of the breast, so it goes from the bud to a teepee to a mound, and it takes, those are the stages here, the 2, 3, 4. It takes 2 to 3 years of estrogen exposure before the lining of the uterus. The lining of the uterus grows thicker in response to estrogen. So it takes 2 to 3 years of estrogen before you will note the first period, okay? So when you start to see, I see lots of families when their daughter develops breast buds. That is great. I love seeing families before periods start, but almost everyone is shocked when they figure out that they then have 2 to 3 years before the menstrual suppression conversation is going to be useful, okay? So just know that, like breast bud, great. Some girls will go faster, but not that much faster. I mean, if you notice bleeding a month after she's gotten breast buds, we need to figure out what's going on, because that doesn't make sense. There's another thing that's going on, and it's called pubarchy. Why we named it pubarchy, which sounds a lot like puberty. Pubarchy is pubic hair, axillary hair, body hair. That is regulated by the adrenal glands, which sit on top of the kidneys. So pubic hair alone it's a different system. Okay, so typically kids will get breast development and then get what's called adrenarche or pubarchy, pubic hair. But because it's regulated through the adrenal glands, and not the ovaries, it really is an independent system. So some kids will get pubic hair and talk to your doctor about that. But if there has been no breast bud, that doesn't mean she's going to get her puberty in that 2 years. Does that make sense? So, and often kids with seizure disorders, special medical needs will have puberty earlier. And again, talk to your doctor if you notice lots of pubic hair, but it really is kind of a different issue to some extent. Yes?
May I ask about bad body odor?
Bad body odor, yes. So that is regulated somewhat by androgens. So it goes with pubic hair. When you see pubic hair, that kind of tells you that your child is making some of that yummy hormone that is also, responsible for body odor. There's not much you can do. It's like a bacterial thing, so you just have to use soap in the underarms, right? That's the most likely place. I mean, there are some other treatments, but it probably just means it would be. Once you have pubic hair, then you're going to be in the situation where you're probably going to have to take a bath every day to address that. Whereas when they're little, maybe you can get away with it. Yeah, good question. The other thing to know is if you see breast buds and the breasts have continued to develop, and it's been 3 years and there still hasn't been a period, that's another reason to be like, what's going on here? Because within 3 years, almost all girls will have a period. Does that make sense? So if your daughter started breast buds at 10, she gets to 13 or 14 and still hasn't had a period, it's probably fine, but we want to know, okay? And sometimes docs don't, they've got so many other things going on, they're not tracking this. Question?
Yeah, so do we know whether puberty onset is delayed or is it consistent in CDD girls?
Great question. We don't know for sure, but looking at and again, it's usually surveys to parents, which are lots of research flaws. No, it might be a little earlier. So let's say maybe, but that was based on one study I read of Rett girls. It's a little earlier, but menarche timing is the same. So I don't really have an answer for you, but it's definitely not. It's not significantly different. It actually defies everything that I learned about puberty. We've always been told there's this magic weight to have your period, and it's 100. Until you're 100 pounds, you're probably not going to have a period. What? With girls with Rett, many of them don't see 100 pounds, and yet they're having periods. So again, I would just say that no, usually they do have onset. I know you're scratching your heads, but that is in a non-medically affected population. Most girls are 100 pounds before they start their period. There's something about that but again, so put that away for this population and just follow the breast. And if you want to look at the breast staging, again, it's pretty amazing. Most girls are tanner 3 or 4 on their breast when they get their period. Okay? And it's really useful, right? Useful information to have. And that's why the doctor, your primary care, is looking at her breast at exam, because it can give you that anticipatory guidance. Okay. So let's dig in just a little bit to what's going on in the uterus, because I feel like this is really poorly understood and really important to understand if you're going to think about menstrual suppression. The lining of the uterus grows in response to estrogen. Okay, if there's no estrogen, the lining isn't growing. So your daughter has had 2 or 3 years of unopposed estrogen going on in the lining of the uterus. The first period is usually not what we think of periods. So, if you're a woman who has horrible 7-day long periods where, that's rarely the first period, okay? But we kind of forget that, and we just picture our daughter having to deal with that when she's 12. Of course, but that's not usually what happens. Usually the first period is the lining of the uterus has just gotten thick enough that some of it sheds. And that's why the first period is often like a 3 to 4 day spotting. You'll notice it in her diaper. You'll notice it when she wipes. You want to confirm it's coming from the vagina and not the rectum. Usually there's more flow than you would expect, like with a hemorrhoid or something like that. But it's often not like the full-blown thing. Often the first period is not ovulatory. So we haven't talked about ovulation yet. The thing that makes us capable of human reproduction as women is we produce an egg from our ovary. The egg then produces progesterone. Progesterone is present for 12 days, and then when pregnancy does not occur, progesterone drops and the lining sheds. So for a girl who has very regular periods, every 28 days, every 30 days, or all of you that have very regular periods and aren't on hormones, it's because you're ovulating every month, you're not getting pregnant, and the lining sheds. I can tell by taking a menstrual history whether someone is basically ovulatory or basically not ovulatory. Often in the beginning, you're not ovulatory. You're having little periods that, oh, well, there was one, and then we went another 40 days, and then we had another one, and then we went, and again, just so you can understand what's going on. Does that make sense, kind of? Okay. Sometimes the first period is ovulatory. Some girls start ovulating right away, and I encourage you to keep track. There's an app called Clue, which is probably my favorite one if you're an app person. Clue, and what's cool about it is we're using a lot of the data to create more information about what normal menstrual periods are, because you can imagine we don't have a lot of research on this, so Clue is a good app to use. Even though periods aren't necessarily ovulatory right away, most girls will have a period at least every 3 months. So if your daughter starts and she goes longer than 3 months without having the next one, note that. That's something to follow. I want to understand that. I may want to check in with you, and we may want to look at her nutrition or what else is going on. And then bleeding more often than every 21 days is also abnormal. It speaks to the fact that she's not ovulating regularly. But what I start to worry about when someone's bleeding more often than every 21 days is that they'll develop anemia, because they are losing blood. And your body will kick in and make more red blood cells, but you need a rest, right? How often are you allowed to donate blood? Is it once a month? They don't let you rest. And I always say that you're not allowed to donate blood more than once a month, like you need. And so we want to check for iron stores. The only physiologic role of the period is so you can reproduce. There is no other benefit to bleeding. There is no cleansing aspect of it, except that if the lining is building up, so if the lining is getting thicker and thicker, it is important that that lining gets shed. And but once we get to the next slide and we talk about menstrual suppression, what we're doing is we're preventing the lining from getting thick. But I know historically, I know culturally, there is thought to be benefits to the period. I think when there used to be like a social benefit, when women used to get to hang out in a tent for a week every month, and talk about their life. There were social benefits to periods. I think, now that we have to go to school and work and, act like we're not having periods, I am yet to find, except for the capacity to reproduce. That's why we have periods, okay? But until you want to reproduce, you don't need to have a period, and then when you're done reproducing, you don't need to have a period, in my mind. I know not everyone agrees with me, but I'm a gynecologist, so there you go. This is a study, and again, this is what I'm talking about when we talk about research. So this is a survey of just 20 caregivers of Rett girls. And again, I show you this because, again, most of the families I'm seeing are interested in treatment, but clearly not everyone. For a lot of girls, their periods are not a big deal. The most common complaint in this study was cramps, PMS, irritability. That's what I hear a lot. Maybe longer periods, which, they just go on and on and on, and families are like, let's do something. 62% in this study, this huge study of 20, had tried hormonal therapy, and I would say for families that do try it, they are very happy. 80 to 90% of people are pretty happy with hormonal therapy once they try it because of the benefits. Not everyone. And then this is another survey. Survey of kids with Angelman syndrome. Again, nearly 2/3 reported a severe symptom with periods, but that means almost 1/3 of families were like, yeah, she gets her period and it's fine. It's not a big deal for us. 2/3 almost 2/3 noted an increase in seizures. That's always hard to explain Estrogen is thought to be excitable to seizures. Progesterone is thought to be calming. However, I can tell you, I've looked at so many calendars with seizures and periods. It is rare to find the girl that actually follows this. However, I feel very strongly that it is, especially if there's hygiene issues with the period, let's try hormonal therapy and let's see what it does to the seizures. But if you're not interested in hormonal therapy, there's good evidence that adjusting seizure meds will also address the increased seizures seen with puberty, okay? So there's lots of ways to get at increased seizures if that's an issue. Yes?
Anything seen after the hormonal treatments, that they, let's say, before they got the treatments, the seizures were higher in the girls, and then they got the treatment, and now they see less because of that, like an increase of medication or something?
Yes, yes. So I definitely have lots of families who when they've started hormonal therapy, they have noticed less seizures. Now, there is not randomized control data because, of course, you guys know sometimes the weather changes and there's less seizures, or you go on a different diet and there's less seizures. So I'm not going to say it's always the case, but it is something to try. What I see is families will talk to their neurologist. Their neurologist is like, well, let's adjust this medicine, and if this doesn't help, why don't you go see the gynecologist? Or the family has a strong opinion. We don't want to do hormonal therapy, so they will just address it through neurology. Or the other way around. They're like, we're sick of seizure meds. Can we please do hormonal therapy? So it really depends on what you all feel is the best approach to try. Yes?
How long can you try hormonal therapy for?
As long.
Can you try it for a short period?
What's a good amount?
I would work.
Should I try for 2 months?
I would speak with your neurologist as the best, and I think it just depends on the severity of seizures. What are you willing to wait? Where are you? It's totally individualized.
Our daughter, since she started having VO, she's 6. Her seizures have gone to like 30 a day.
Wow.
Going from like less than 10.
Right.
Does hormonal
Right.
therapy interact with CBD?
Well, the other thing to say is, not that I'm aware of, but hormonal therapy that I'm talking about, menstrual suppression, we will not start until someone has started periods.
Okay.
So there might be other hormonal therapy that you guys could talk to an endocrinologist about, but it is not appropriate to start hormonal therapy, and we're going to get to it in a second, to suppress periods until your daughter has had at least one period. And the reason for that is lots of reasons. Though estrogen exposure over the years is so important to her bone and brain development, we are not going to. Now, if she has precocious puberty and you give like Lupron to stop her puberty, to allow more, that's a different story. But for a girl who develops breasts at 9 or 10, you want to give her body those years to bathe in the estrogen, to go through the natural process. And the other thing is, believe it or not, and I see lots of patients who don't have a uterus, who don't have a vagina, who don't have ovaries. And, that can happen to any girl. And so if your daughter gets to 13 or 14 and hasn't had a period, we need to understand why for her, just like any other girl. And it could be that she has, be unrelated, I think, to this condition, but that she has an anatomic issue or something like that. And we would want to know that because we wouldn't be wanting to give her medicine to stop a period or worry about fertility when indeed she doesn't have any fertility. And then we may need to give her hormones to support her bones. Does that make sense? But so the body odor issue, I would say you've got to attack it through antibacterials and, that kind of thing.
Yeah.
But it is an issue, yeah.
Now, after she starts her period,
Yeah.
and go on the hormone suppression, is that going to affect her bone growth or?
Great question. That leads perfectly into this one.
Oh.
So if you come to see me, and there's a handout, are you guys getting handouts electronically, I guess? There's a handout that I use every day with families when they come to talk to me, and it looks a lot like this. The way all these medicines work is we talked about progesterone and how in the natural state for an ovulating woman, you get 12 days of progesterone every month, 12 days of progesterone every month. Progesterone causes the lining of the uterus to mature, and then when it goes away, the lining sheds. When you give constant low-dose progesterone to someone, doesn't matter if there's estrogen present, the lining doesn't thicken. So constant low-dose progesterone a girl makes her own estrogen, the lining of the uterus is not going to thicken in the same way. And so that is why there is no need for periods, okay? Because the lining is not building up. Some of these methods suppress ovulation, some do not. So we'll go through them. So all of them contain progesterone. The pill, the birth control pill, the patch and the ring, and most families aren't interested in the ring because they don't want to put a vaginal ring in their daughter, but the pill, the patch, and the ring also contain estrogen. They contain estrogen and progesterone. The estrogen was added 60 years ago. Pills were developed for women to not have babies. It's so ironic now because I almost never use the pill in my practice when a girl wants pregnancy prevention. When a teenager comes to see me and says, I'm in love, I'm having sex, I want to go through college without having a baby, I recommend an IUD or an implant for her. So it's funny, even though the only one on here called birth control is the birth control pill, my practice, I usually am using birth control pills for younger teens or teens who aren't sexually active to manage their periods. And I just think that's funny that the one that has birth control in it, I don't barely use for birth control. So these are all just medicines. I tell families if I could take them out of the packaging, if I could change FDA labeling, I would. The only one in here that's actually marketed or labeled not for birth control, there's two of them. There's the progestin IUD, which is the Mirena IUD, now has an FDA labeling for the treatment of heavy periods. Okay, and we'll go through how all these work. Norethindrone acetate is an oral pill of just progesterone. Usually I give 5 milligrams, but you can go lower, 2.5. It's a pretty soft pill, so families have pretty good success, crushing it up, putting it in a G-tube. And it's a daily dose of progesterone so that the lining does not grow thick. Families can suppress periods really easily with it. Usually people can go, there's always some adjustments with all these meds, but usually you can go 90 days, take a 5-day break, have a period. Many girls can go much longer than that, okay? It does not have any estrogen in it, it's just progesterone. And what's nice about that, the estrogen-containing ones, birth control pills do slightly increase the risk of having a blood clot or stroke. It's a very small increase. It's considered an acceptable increase. Birth control pills are going to be over the counter in Colorado very soon. They're over the counter in every other developed country. Okay? They're as safe as ibuprofen. Ibuprofen has lots of scary things that it can do to you too. But there is a small increased risk of blood clot and stroke with birth control pills. And that's why if your daughter has a medical condition where she already has an increased risk of blood clot and stroke, we're not going to give her the pill. The one place where the pill is very helpful, it is a treatment for acne. So if acne is very genetic, so if you've had severe acne or your husband has had severe acne, guess what? It's another thing we can give our children. And a lot of families will go to the pill, the combined pill, to also treat their acne at the same time, which I think makes a lot of sense. The way we were all given the pill, where we got it for 3 weeks and then we got a placebo for a week and had a period every month, yes, that was totally unnecessary. Those 20 years I spent on the pill, having a period every month and no one told me. You don't have to do it that way. You can stay on active pills and just do a break, either because you have breakthrough bleeding or because you want to do a period. Question?
The norethindrone
Yes.
acetate, is it suppressing all of the PMS symptoms as well?
It's such a great question. It has not been studied as a contraception. So it definitely suppresses the period. It probably is strong enough that in most girls it feeds back so that ovulation does not occur. If ovulation does not occur, PMS does not make sense to me. But what I say to families is we try it. Come back in 3 months or email me sooner. The nice reason about the pill and the norethindrone that families like is if you hate it, it's out of her system in 24 hours. Which is so nice, right? When you have a kid where you're just like, everything we do, she reacts weirdly to. And I say to them, listen, let's try it. If you don't like it, within 24 hours, it will be out of her system. And because then you can try it again. Well, maybe it wasn't that gave her the rash. Maybe it was the strawberries. So that's one of the advantages.
And so you would take that one every day as well?
Every day. And one of the issues with the pill and the norethindrone is if you miss it, if you forget, or she's sick and she doesn't get it, well, what's going to happen? She's going to start bleeding. Because the lining of the uterus, it's that drop. So, you know, it's not that big of a deal, but especially I have a couple patients that go back between mom and dad. Mom forgets to give it, dad gets the period. Dad forgets to give it, you know, and so for a lot of reasons, sometimes the pills are not, that would never happen in your family, right? It is when you look at graphs of what's called extended dosing with the pill and the norethindrone, the first 1, 2, 3 months, there may be a lot of spotting. So my nurse gets a ton of calls from moms who's like, we started this medicine to stop her period. She's had 4 periods this month. This is awful. And it's usually not awful. It's just that, you know, you started a pill to make it better, and there is an adjustment period until you get to the point where you have control. Okay, so that is normal. So it's not like instantaneously you're going to be able to go 90 days. You might, but about half of girls will have breakthrough bleeding where you need to take a break, then you start again. You know what I mean? And it is the kind of thing where usually, like for teenagers who want to control their period, I have them set a timer. And you often are very good about that because of seizure medication, right? Like you're very good about giving at the same time. Okay, so those are that. Depo-Provera. Now Depo, which is get back to your bone question. The other ones, the pill has estrogen in it, so we don't worry about bone loss with that. The norethindrone is not as strong as to suppress estrogen production, and norethindrone has been studied a lot in women with endometriosis. Endometriosis is a condition that can cause pelvic pain. We use norethindrone a lot in women with endometriosis to suppress their pain, and we have studied their bones. It's not an equivalent population, but at least we have some data that it does not harm bones. It's actually protective to bones. Depo, however, is very strong. It's progesterone only. It keeps the lining of the uterus very thin. It also feeds back to the brain so that estrogen levels are lower. Now, not like menopausal lower, okay? So it's not like we're taking a girl who's on Depo and putting her in menopause. It's not like Lupron, which is a medication to treat precocious puberty. But over time, her estrogen levels are lower, and there have been studies that show that bone mineral density decreases on Depo. And again, it's not been studied in this population. It's been studied in women. Normal, reproductive age women are using Depo for birth control. The changes are reversible when they stop the Depo. When you breastfeed, you lose bone mineral density. I mean, there's other times in our lives. However, I know the guru for RET who doesn't, one of the guys, I mean, there are lots of providers who will not use Depo in girls with Rett syndrome, and again, just that's the one I'm focusing on, because girls often have other risk factors for low bone mineral density already, not weight bearing, small BMI, seizure meds, which already negatively affect their bones. So we used to not really have all these options. 20 years ago, it was, do you want the pill or do you want Depo? So Depo was by far the most popular choice. It's an injection you do every 3 months. You can come into the office for it, but there is a home version of it, so I can send it. So it is a lot easier for parents who don't want to be smushing up tubes or fighting pills or fighting about giving a pill. However, I do think the concerns about bone mineral density are real, and I do try to really talk to parents about other options. Depo used to be thought to be like a wonder drug when it came to seizures. So for a long time, neurologists were even promoting Depo to help with seizure control because, again, progesterone is thought to be estrogen is thought to be excitatory and progesterone is thought not to be. That data has not continued to pan out. When I see a family who's been on Depo and they think it has helped them so much, I am not going to refuse to give Depo to them. I might ask them to get a bone mineral density. We will look at bone mineral density. For bone mineral density tests, your daughter just has to lay there. Usually they can do it quite easily. If bone mineral density is extremely low, then I'm going to want them to consider an alternative to Depo. Okay, does that make sense? Depo is also really good for pain. So when I have kids with like complex CP, with spasm, I mean, sometimes Depo plays a lot of roles, not just the menstrual suppression. But I would say lots of families may not even get it offered because of the concerns about bone mineral density if your daughter already has additional concerns about bone mineral density. Does that make sense? Okay. The progestin IUD. This is rapidly becoming like the most popular option, and not just for menstrual suppression. There is a joke in gynecology right now, like to open a practice, all you need is a shingle and a bunch of IUDs. So the progesterone IUD treats, well, great for birth control, treats heavy bleeding, offers menstrual suppression. You get it, and it's FDA approved for 5 years, but it's effective for 7. So for kids with special needs, they go to sleep, we go to the procedure room and the OR, we can coordinate with other surgeries, like if your daughter needs dental work or ear tubes or whatever the case. When she's asleep, we put her legs up into stirrups. The vagina is open, we put a speculum in the vagina. When she's asleep, everything's stretchy. She may have like a little, sometimes there's like little scratches from what we do, but it's not, we're not cutting, the space is there. We look at her cervix, we introduce and we measure the uterus, and then we dilate the cervix, which dilates just a little bit so we can place the IUD. The IUD goes in like a straw, and then the arms open up into her uterus. The uterus is the size of a fist. Even in girls who are small, the uterus develops to the adult size. Most women have about the same size uterus, even if other parts of them are small. And the IUD just sits inside. It's about the size of a quarter, and it just sits there. It releases progesterone locally, and then the lining of the uterus doesn't build up. Menstrual suppression rates are around 90%, 80% of girls don't have any bleeding. Medically, we love it because the progesterone is local. So especially in girls who have complex issues, again, maybe not your daughters, but for girls who have transplant and for really complicated medical issues, doctors love it because the effect is local. It's not giving their whole body hormone. So that is the Mirena or Liletta IUD. A lot more women are using the IUD too, so just the comfort with it. Mom has had an IUD or her friend has had an IUD. Most OBGYNs, we use IUDs for ourselves. So when people tell me, oh, they're so scary, I'm like, okay, when you go to buy a car, don't you ask the guy who sells the cars what he drives? So again, historically, IUDs were something scary, but that was based on an IUD in the 70s, the Dalcon Shield, which was designed really poorly. It was also based on some very bad data that said that women who get IUDs are infertile and get pelvic inflammatory disease. What they weren't doing is they weren't looking at the rates of chlamydia. So chlamydia causes infertility and pelvic inflammatory disease. The IUD does not. It was just an old study that was poorly done. And so IUDs do not increase the risk of STDs or infertility. And for families who want something where they get it done and then they're done, and they know that their daughter will have good menstrual suppression, treatment of cramps, and God forbid, be raped and have great birth control on board, it's a very nice option. So just want you all to know about that. Yes?
Would you recommend, because we live kind of like
Yes.
our smaller town.
Yes.
Would you recommend going to a gynecologist that has special needs experience?
That is such a great question. I think it depends on you. If I lived in a rural town, I would walk in with the I would know the OB. I would have my regular OB do it, honestly, because I don't think, so we, as OBGYNs, we place 5 IUDs a day in the office with an awake patient. So putting an IUD in under anesthesia is like the easiest possible thing for us, right? Because it takes out the hard part, which is managing a woman's pain. So it's a very easy procedure. So if you have a good relationship or you feel comfortable with a local OBGYN who places lots of IUDs and thinks that they're a very good thing. There are still some older OBs who think they're bad. I would not go to them. Someone who positively approaches this. There is a lot of published recommendations in our literature, the American College of OBGYNs. The IUD is a recommended option for girls with special needs who want menstrual suppression. So I would meet with them, and they should offer it as an option. And there would be no reason, now except for the way she's treated with anesthesia, you know how it is, right? If you show up in a place that doesn't take care, I think that's the benefit to coming to Children's to have it placed, is that you'll be able to walk back with her to the procedure room. You know what I mean? We're used to doing that. Not so much about the technical aspects of placing the IUD. Yes?
So you said the IUD is local and it doesn't affect the pituitary and estrogen production?
Yes, it does not. And what's so interesting, you asked about the PMS symptoms. So the IUD doesn't necessarily prevent ovulation. So the question is, well, if I give her an IUD, will it help with her PMS? It does. So why though? And that's what we don't understand. We don't understand PMS really. I think because PMS, although it is related to, the progesterone, it's also related to just the release of prostaglandins and like all the crap that happens in your body when a period's coming.
The gland's gonna get the signal maybe?
What?
And the pituitary gland will maybe get the signal and
I mean,
go down the road.
in half of women it does prevent ovulation. It just doesn't reliably prevent ovulation. But so for a family, when they are really concerned about PMS, or they are really concerned, I say to them, I'm like, well, maybe the IUD isn't the best choice because it is going to be local. But I can also tell you that what I do a lot is we place the IUD, and if there are still PMS or if there's still lots of spotting, I will add on an oral hormonal medication in addition to the IUD to see if that helps. Does that make sense? Okay, and it is still a procedure. There are still risks of procedure. There's a risk of expulsion where you get the IUD placed and our body squeezes out. So it's not like a perfect thing, but it is something that you all should know about. And if you're not being offered it, I think that's not appropriate either. Yes?
Having a daughter who's on the older
Yes,
side of everything.
yes.
And having tried a couple things.
Yes.
Where it's been more of behavioral mood swings.
Yes.
That we've seen, that
Yes.
we've decided to remove.
Yes.
What is, as a gynecologist, your thoughts of having an ablation or some form like that versus having something invasive every 5 years? So if
Yes.
she's going to get an IUD and we're going to do every 5
Yeah.
to 7 years, it's still
Yeah.
invasive to me.
Yeah, yeah.
So
So-
on the older side.
Yes. So I'm so sorry. I was not watching my clock and I'm already out of time. So let me
We
get
can
to
discuss
that.
that.
No. That's a great. Ablation is not an appropriate thing to offer. Ablation should only be offered to women when they are close to menopause because the lining will regrow, and once you've had an ablation, you can't put in an IUD and you can't ablate again. So I know it's being offered. I would say that's not appropriate.
Okay.
After ablation, guess what's next? Hysterectomy. Which again, I mean that a hysterectomy is an option for gynecologic reasons, which you're going to be there after a failed ablation. That's what's the next thing is a hysterectomy, which may be needed. I mean, as your girls get older, they may develop fibroids, they may develop other things, but I do not think ablation is appropriate. Women who have ablations in their 20s and 30s, they will fail, usually, because the lining grows back. So it's a nice idea, but it doesn't usually work long term. Okay, sexual abuse, it's out there, be aware of it. This is a good book if you're a book person. Pap smears and HIV, I just want to clarify this real quick. The American College of OBGYNs, GYNs, we don't have any reservations about recommending HPV vaccine. HPV causes cancer, doesn't just cause cervical cancer, it causes anal cancer, oral cancers. Almost all head and neck cancers in men are HPV related. So we recommend HPV vaccination. I will let you take that up with your primary care, and ideally it is designed, or not ideally, it was designed to prevent cervical cancer. HPV is usually acquired through sexual contact. If your daughter is never going to be sexually active, the question is, why does she need an HPV vaccine? I understand that. I'm just telling you that, that's kind of my line, and that's going to be most OBGYN's line. In terms of whether or not she needs a pap smear, there is only one recommendation right now for pap smears. All women should have a pap smear at age 21. The only way to do a pap smear is through a pelvic exam. There is no value to the pelvic exam in itself. The pap smear screens for cervical cancer. Women who have never been sexually active have an extremely low risk of cervical cancer. So I don't just put people to sleep, or I just don't do a pelvic exam on a 21-year-old woman who's never been sexually active. I'm going to sit down with her and her family and say, we're screening for cervical cancer. Would you like a pap smear? If they're like, yes, this is really important to us, okay, let's do a pelvic exam to get a pap smear. If on the other hand, they're like, my risk of cervical cancer is less than 1 in 10,000, considering I've never been sexually active, I'm going to defer that test. So just understand that the pelvic exam is no longer thought to have any benefit from a screening standpoint. The only reason you would have a pelvic exam is to have a pap smear. Soon, I think we're going to be able to do HPV testing through urine. So I'm hopeful that within the next 10 years, maybe some of your younger girls at 21 will have a pee in a cup. We'll see if they have HPV. If they would have HPV, okay, we got to go figure out what to do. But if they're HPV negative, you can take that off your list and feel, okay, my daughter's had appropriate screening. But how many people, when I talk to them about this, are like, did you have your colonoscopy at 50? No. Are you late on your mammogram? And I'm not saying that's good, but I do want to empower you guys to decline recommended screening if you feel like it's not the right thing for your family. Does that make sense? I'm not anti-pap smear. I will definitely do pap smears, and sometimes I can do them in the office blindly, where I just put the swab in the vagina with a parent, and we get some cells from the cervix without doing the full-blown thing. So there are lots of ways to skin it, but I don't want you to stress, and I don't want your primary care to make you feel like your daughter's going to have a pelvic exam when she's 21. Okay? Make sense? Okay. And then any other questions I'm happy to answer. I'm so sorry that I lost track of time. Yeah. And do you guys want to come up? Do you want me to do them over the loudspeaker? I'll just do them over here, but feel free to leave, but then other people can hear. Feel free to leave.
Just for younger kids, so a lot of our kids have been on steroids for a while.
Yes.
In terms of, that's what I told you. Does that increase the chances of early puberty?
No. No, it does increase the risk of low bone mineral density. Yeah. Precocious puberty.
My daughter's 5, and we noticed she has breastfed body odor.
Yes.
And we're going to see it now.
Yes. Yes, it is more common, but there's lots of different causes. So she needs to be worked up for central causes, where puberty is started earlier from her brain, and also peripheral causes, where estrogen is being produced maybe by an ovarian cyst. That would give her breast development. Sometimes also after testing, it might just be, I don't know how developed your breasts are. Sometimes people see breast buds, but then when an endocrinologist does the exam, they're like, there ain't breast buds, and does lab work and sees that the estrogen's lower. But it is the pubic hair is being driven by adrenal hormones. The breast bud is being driven by estrogen made from the ovary. So they are different issues, and that's why it's really good to see an endocrinologist who really understands that all. No, I would have her start with an endocrinologist. Endocrinologists, pediatric endocrinologists, at least in our institution here, are still the ones who primarily deal with precocious puberty, because then they're going to give them Lupron to suppress. It's the same situation like if you're, Yeah, I think that's completely appropriate, and then they will get us involved if there is an ovarian cyst or if there is something that needs to be addressed.
Okay, great.
Yeah. Yes.
Just to sum up.
Yes.
So in my child, she's 16.
Yeah.
She seems to be right on track.
Yes.
She's got a period.
Yes.
Everything seems to be
Great.
normal. My concern is parents, where my mind goes, and I know there's no judging.
Yeah.
We're in a
No.
safe zone here.
Yeah.
I go to, I'm afraid she's nonverbal, so
Yes.
I want to make sure she's comfortable.
Yes.
My other daughters had a very hard period.
Yes.
They're older now and doing
Yes.
better, but they've been on the pill and done their own
Right.
treatment therapies. So my mind goes, what can I do to alleviate her cramps, because she can't communicate
Yeah.
to me. So I hear you, you talked about the first 2 pills, the noro one,
Right.
acetate one, so I'd never heard that before.
Yeah.
Or then I hear the IUD, which seems medication, then IUD. My brain goes, why don't we just have hysterectomies but leave the ovaries? So
Right,
we're not dealing
right,
with any of that.
right.
And then I think, well,
Right.
what's,
Well, first of all, I want you to let you know that, I am a huge proponent of hormonal therapy, but I do want to be devil's advocate. Only 1 out of 4 girls has really bad cramps. And if your daughter could be 3 out of the 4 who have no cramps. So please don't just give her medicine because, she can communicate. And if she, you know her best, but if she is truly a star through her period, she may not be having cramps. Not everyone, or she doesn't have them yet because she's just started her periods maybe. But 1 out of 4 women has severe cramps. 3 out of 4 do not. And I see that all the time in my practice. A mom has had horrible cramps. The daughter is having none. Mom is like, she needs to go on something. The daughter's like, periods don't bother me. And then the worst is the opposite, where the daughter's missing school because of her cramps. Mom's never had a cramp in her life and thinks that her mom is making the whole thing up. So, I mean, I see that it's not familial, it's just the way you're wired, okay? So don't feel like your dog, I mean, I think you would know if she was suffering. And oh, okay. So the other thing in Weather Study, ibuprofen works really well too, so if you didn't want to go with hormonal therapy. Okay. So with the benefits, I would just look at the list and see what's going to be best for you. The reason we don't do a hysterectomy, it is pretty clearly established that that's not an ethical thing to do for her. It's a major surgery, although hysterectomies routinely go great. It's not like just sitting there. You have to dissect it away from the bladder and the bowel. We're never going to do that without a ethics board. I mean, there's no, because it's taking away someone's potential to have a baby, and we have a long history of doing that unfairly in our country, and we're not doing it anymore, which is a good thing. Also, once you remove the uterus, you're removing some of the blood flow to the ovaries, so women who have hysterectomies do have an earlier onset of menopause. That's not something you get counseled about when you have your hysterectomy, but it's important to know, so I wouldn't want to do it from that standpoint. And then I would just go through the options and just see, and know that you're just deciding for now. Lots of women, most women will do all of these. I mean, I've tried myself to do all of them, and I'm running out of time. I have never done the implant.
So with
But
the first one, the 2 pills versus the IUD, did you say one of them suppresses periods? And then I think caretakers.
Oh.
You know, and that's,
I would outline what you're trying to do. I thought you were going to say something about the fear of sexual abuse. That's what I thought. And so I love the IUD as a long-term strategy, especially, again, I don't think it's, so a lot of the girls I treat with special needs, as they get older, they're more in the environment. They're maybe going to a day program. You know, there's just a lot more, maybe they're getting a job. There's a lot more contacts. And I feel like the IUD, it offers, of this list, I mean, it's better than the pill because you can't forget it. You can't not get to the pharmacy. So it offers that extremely high level of protection from pregnancy if something would happen.
more medication, so I thought how many meds is she
Exactly. That's the other, that's why a lot of families choose it as well. And again, there's no rush to do it. So think about, does she need to go to sleep for an MRI? Does she need dental work? So then when she goes to sleep, she can have several things done. Instead of just putting, now trust me, it's easier for me when they just get put to sleep for the IUD. So I don't have to wait for dental, but think of it that way. Think of it being like on her 5-year plan. Yeah.
Put them all together.
Yeah. Yeah.
I have a
Yes.
question.
Yes.
Does that cause any side effects? Like, I hear people say, oh, they get migraines or
Yeah.
things like that. Does
Yeah.
that do
No.
that? Okay.
I mean, there's a lot of ads right now by trial lawyers too that I've heard a lot about. It's a really local. When you look at control groups, so like the best control group is the copper IUD. The copper IUD has no hormones, and so we look at the groups together, and like 10% of women will have headaches. 10% will have, you know what I mean?
Yeah.
So it's comparable to placebo, which is our best. Now, there are some women who are really sensitive to the progesterone, and maybe they'll have a little more acne or something, but you can't beat it in terms of like local menstrual suppression and the ease of use. So it just takes, everything else out of it, which is really nice. Yeah. Yes.
My daughter is profoundly challenged.
Yes.
She sees an endocrinologist. Now, she has osteoporosis.
Yes.
And she didn't start her period till she was 18.
Yes.
She's now 21. Well, actually, did 22. She noticed that, and when it came monthly,
Yeah.
pretty regularly.
Yeah.
And her bone health got a little bit better.
Good.
And we noticed that she'll grind her teeth when she's
Having cramps?
Her period's gonna start,
Yeah.
like before it starts.
Yeah.
I don't know if she's having pain.
Yeah.
So, I do give her ibuprofen.
Yeah.
But just the other day, I'm like, she's grinding her teeth. She just had her period 2 weeks ago. Lo and behold, while we were here, she started her period again. It's only been 2 weeks. So now you said
So
about-
she's having it, one of those cycles was anovulatory.
So like,
the,
I'm thinking, oh my gosh, is she anemic? Should I have
no, I'm talking like long term. No, but if that continues, I mean, you're going to want to do something so that she doesn't have to suffer like that. And I think with the norethindrone or the pill, you're not going to take a step back with her bones. You know, I mean, if you wanted to give hormonal therapy to,
When I had my period,
yeah,
you know, I used to have terrible cramps, right?
yeah,
I was sick and throw
yeah,
up the
yes,
next day.
totally, totally.
So I don't know if she's having pain, so she's probably.
I think she is.
She has to.
I think she is,
Yeah,
yeah.
so I'm thinking, okay, the first one.
The norethindrone, yeah.
Would that be a good option for her?
Yeah, or the pill, or the combined pill. Is there any reason does she have other risk factors for blood clot or stroke? Like, does she get migraine? I mean, is there any, I would talk to, I mean, she's old enough that, do you have had that conversation about the pap smear?
No, I don't know.
Well, so there might be a couple of reasons you can hit off. Well, no, but sometimes the
I really
primary
don't
care
want to
is,
do that to her
I know,
because,
I know,
you know,
I
it's
know.
just, she wouldn't understand and.
Are you on an adult endocrinologist now? Okay. I mean, I would talk to them, and if they're probably not going to be comfortable, they're probably going to have you see a gynecologist to talk about the options. Maybe your primary care would be comfortable prescribing. Endocrinologists often don't do a lot of menstrual regulation. Now, maybe yours does. But in my experience, usually the endocrinologist will have the girls see me. Doesn't mean that I have to be in the life forever. Just have once, get it started, and then. But yeah, I think any of them are going to help. The only one I wouldn't do, obviously, is the depot because of the bone concern. But the norethindrone acetate, is she on other pills?
She is on Epidiolex.
Okay, that's it.
Cut her seizures about 60%.
But that's it. That she's not on. But you give it.
And was in a trial, so she's on it 5 milligrams of Onfi.
Yeah.
Which I can't wait to cut that out.
But you're already giving her medicine, so it's not like giving a medicine is a burden for you or her.
No, she's
Yeah.
an angel.
Yeah.
She takes medicine.
Yeah, I would say the norethindrone or the regular birth control pill. Yeah, but I wouldn't give the regular birth control in the regular way. I would probably just start the norethindrone and see, and just have her have a period every 3 months, but you can plan it. So you're going to keep her on the medicine, and then when it's a good time, you're going to give her a 5-day break. She'll have a period, and then you restart.
Actually, our endocrinologist, we talked about doing that.
Oh, good.
So, I
Good.
just wanted to hear what you
Yeah, no, I think that would be fabulous.
But she said the pill, and I had never heard the other drug, so.
Well,
I'll
and
bring it up.
you could bring it up.
Is there one better than another in your opinion?
No, they're it's not like toothpaste. You know, they're all like the same but different.
It's funny you said that.
Yeah. No, they all a little different, but they're all basically the same. I bet she'll probably use microgestin or low estrin. That's like the most common one used by, it's just been around the longest. It's very safe. So she'd probably put her on low estrin. And then, just do the actives. And then if she has breakthrough bleeding, which means she has bleeding when she's on the actives, give her a 5-day break, let her have a period, and then restart. And the longer you do it, the longer you'll be able to go. So some girls never need breaks. They can take an active every day and never need to do a break. Yeah, it's really nice.
Okay, well, that's good.
Good. Well, I hope that was helpful.
Yes, very.
Sorry, I lost track of time. Should probably log out, huh?